I am Felipe Teran. I am an emergency physician from the Division of Emergency Ultrasound and Center for Resuscitation Science at University of Pennsylvania. This is the first of two webinars on the implementation of transesophageal echocardiography in the emergency department. Over the past few years, I've been dedicated to study, train, and teach TE at the point of care, and I have been fortunate to work on the implementation of two resuscitative TE programs in New York City and more recently at University of Pennsylvania. This presentation has been prepared by me and represents my own perspectives and experiences on this topic. It does not represent a comprehensive training for the practice of transesophageal echocardiography. Providers should not perform this bedside ultrasound examinations and procedures solely in reliance upon the information in this presentation. During this first webinar, we will mention some of the most relevant publications that anyone getting in the practice of TE in the emergency department should be aware of. We will then briefly discuss what constitutes a program for resuscitative TE and the importance of clearly defining the scope of practice. We will then discuss some of the practical aspects of getting a probe in your department. And finally, we will cover the basics of cleaning and maintenance of a TE probe. During the second webinar on this topic, we will cover what are the main training options to gain the necessary skills to perform TE. We will briefly touch on the topic of credentialing and institutional privileges for the practice of point-of-care TE, and then we will finally review some of the main resources available for learning and training in TE. So without further ado, let's dive into the key articles that you should be aware of if you're in the process of starting to do TE in the emergency department. The first publication, and arguably one of the most important papers, is this case series published in Resuscitation exactly a decade ago in 2008 by Michael Blivas. In this case series, Dr. Blivas reports the first experience of an emergency physician performed TE using a focus protocol specifically in cardiac arrest patients. These cases were selected from among 15 TE resuscitation cases occurring over a 6-month period at a large tertiary care emergency department. Just to give us an idea of what kind of role TE had, here's a brief description of these cases reported by Michael Blivas. The first was a 35-year-old male with out-of-hospital cardiac arrest who came in PEA. Limited transthoracic show no cardiac activity. At that point, decision to stop resuscitation was made, and following this, a TE was inserted, which showed pseudo-PA with an EF estimated in 15%. Following this, the team decided to give pressors, and given the improvement, the team continued resuscitation, and eventually the patient achieved ROSC. This patient was reported to be discharged from the ICU 2 days later. The second case was a 73-year-old female who arrested in the ED in asystole, had a TE place which showed fine ventricular fibrillation. The patient was defibrillated. CPR was optimized under TE guidance. Eventually, the labs demonstrated the patient had a potassium of 9.4, which was treated, and eventually the patient achieved ROSC. This patient also was discharged from the ICU 8 days later with reportedly normal mental status. The third case was a 73-year-old female with out-of-hospital cardiac arrest in asystole, whose initial TE showed cardiac standstill. CPR was started. A subsequent TE examination showed fine ventricular fibrillation. The patient was defibrillated and eventually achieved ROSC. In a subsequent TE examination, the team found the patient had a large thrombus in the right atrium, for which the patient was given TPA and treated for suspected PE. That is pulmonary embolism. The patient was reportedly admitted to the ICU and died from hemorrhagic complications days later. The fourth case described in this series is a 45-year-old male with out-of-hospital cardiac arrest in refractory ventricular fibrillation. This patient had a TE performed at arrival, and the TE demonstrated that a PICC line, a PICC catheter, a peripherally inserted central catheter, had the tip moving in the entrance to the right atrium, periodically striking the wall. The team thought that this was likely causing the patient going into refractory ventricular fibrillation, and therefore this PICC line was pulled back, and eventually patient achieved ROSC. This patient was discharged from the hospital. Case 5 is a 35-year-old male with DVT and PE on anticoagulation who was being evaluated in the emergency department with chest pain. This patient arrested while in the emergency department. The first rhythm was pseudo-PEA. The team thought this patient had a pulmonary embolism, and therefore, while TPA was being prepared, TE was inserted and showed no signs of RV dysfunction, but instead a proximal aortic dissection. The patient was then taken by CT surgery to the OR and was reported to be discharged after a prolonged course to rehab. The last case Michael Bleibas reports is a 61-year-old female with out-of-hospital cardiac arrest in PEA and intermittently in ventricular fibrillation. Transthoracic echo had shown possible RV strain. The TPA was being prepared, and eventually the patient had a TE placed, which showed that the patient actually did not have any RV strain evident on the TE, but persistent fine ventricular fibrillation. For this, the patient was shocked and eventually achieved ROSC. This patient was found to have a subdural hematoma leading likely to the arrest. In this case, the patient died in the ICU days later. Building on the experience reported by Bleibas, several years later in 2015, Robert Unfield and colleagues from Western University in London, Ontario, Canada, reported in Clinical Ultrasound Journal their single-center experience conducting a brief and focused TE training on a group of 14 emergency physicians. This publication was titled Focused Transesophageal Echocardiography for Emergency Physicians, Description and Results of a Simulation Training of a Structured Four-View Examination. In this study, they report that following a 4-hour didactic and simulation-based workshop, these physicians were able to adequately obtain and interpret TE views and acceptable retention of the skill at 6 weeks. Of course, there are several limitations to the study, but it was the first report describing the feasibility to train providers in the FOCUS protocol with a simulation-based workshop. The third study in this is the second publication from the same group published in the Journal of Emergency Medicine in 2016. This was a retrospective review of all ED-TE examinations carried out between 2013 and 2015 at their institution. The most common indications for TE were intracardiac arrest care in 43%, post-arrest management in 26%, and undifferentiated hypotension in 40% of the cases. In this report, TE imparted diagnostic influence in 78% of the cases and impacted therapeutic decisions in 67% of the cases. The next study was a brief report from the group at University of Utah, led by Dr. James Fair and Joseph Tona. In this study, the group describes their first 2 cases of ECLS, that is extracorporeal life support, which involves placing selected patients on ECMO during cardiac arrest resuscitation as a bridge to immediate survival. Why is this relevant to those performing TE in emergency medicine? Because TE was an integral part of the cannulation process in this case series. In 10 of the 12 cases, emergency physicians performing TE were able to confirm the location of venous and arterial guide wires before moving to dilation and cannulation phase. As reported here by the group at University of Utah, many other centers performing ECMO in cardiac arrest are using TE as an integral part of their programs. The next study is another simulation-based prospective educational cohort conducted, in this case by a group at VCU in Richmond, Virginia. In this study, following a didactic lecture, 40 emergency medicine residents underwent 3 different simulation-based training sessions over the course of 3 consecutive weeks, followed by an individual simulation-based assessment to test the residents' ability to develop and interpret both normal views as well as some of the most common findings seen in cardiac arrest, such as cardiac tamponade, fine ventricular fibrillation, or asystole. This study showed that emergency medicine residents can rapidly perform TE studies in a simulated cardiac arrest environment with high degree of precision and accuracy. Finally, the last article anyone implementing a program for resuscitative TE should know is a recently published policy statement by the American College of Emergency Physicians titled Guidelines for the Use of Transesophageal Echocardiography in the Emergency Department for Cardiac Arrest. In this guideline, the objectives and limitations for focus TE in cardiac arrest are described, and general guidance is provided regarding qualifications and responsibilities for clinicians performing TE examinations, as well as documentation, equipment, safety, and quality control. The first thing I wanted to share is the importance of clearly defining the scope. This is focus or resuscitative TE. You need to have a protocol where you describe the goals, the patient selection criteria for this program, the physician requirements, and the probe processing workflow. This might seem silly, but I've learned that while we might be clear in what we're doing, our colleagues, especially those that are not necessarily ultrasound folks, might be confused. This is a visual aid that we put together with graphics generously provided by Hardworks, summarizing 4 views included in our institutional resuscitative TE protocol. Pocket cards of these were made as a part of our program's effort to disseminate this information and educate providers in our department regarding the applications of TE as described in our protocol. Regarding the TEE probe, most of the companies we're using in point of care in emergency medicine have by now available TEE probes that will work for your machines. These probes are between $30,000 and $45,000 and will require all the processing steps I will describe shortly. Sonosite has had a TE probe for years and was in fact the probe used in both Michael Bleiba's case series as well as in the feasibility study published by Robert Arnfield. The TE probe has 3 main components: the controller or housing for the knobs that provide the different movements, the shaft, and the piezoelectric crystals, which are located at the tip of the probe. The 2 wheels located in the probe, commonly in the controller of the probe, commonly referred as big wheel and small wheel, provide anterior-posterior flexion and lateral flexion respectively. The 2 buttons located on the side of the controller provide 180 degrees of rotation of the omniplane. That is the direction in which the ultrasound beam is generated by the crystals, which can be seen in the top left of the image as shown here. Now that you have obtained a probe and understand the components, let's dive into cleaning and maintenance of it. TE probes do not need to be sterilized. They need to be high-level disinfected. I'm going to describe step-by-step our current process. We send our probe to be cleaned by the Central Equipment Processing Department located in the ORs. We use a bin system with utility racks that are used hospital-wide for instrument processing. After being used, the dirty probe is placed in one of these bins at the bedside. Just of note, the Joint Commission states that dirty equipment that was in contact with body fluids should not be left in the room until it goes directly for cleaning. One of our friendly and kind ED technicians then transports the probe for equipment processing. Once there, is left for phase 1 of the process, which is decontamination. As with most surgical equipment, there is a digital barcoding system that allows to track our device. And this is very helpful if you only have one probe and you want to get it back on time for next use. Regarding specifics of how to clean the probe, the viewers should refer to the cleaning protocol established by infection control at their respective institutions. I will say that unlike what many people think, having gone through the process of setting up the processing workflow for our probes at 2 different hospitals, this is actually something fairly straightforward. A comprehensive and detailed website with information regarding TE transducer care is available in Sonosite's website. There you can find a detailed step-by-step description of both the cleaning and disinfection phases, as well as a list of the different disinfectant products that are commonly used at the specific temperature and duration for each of one of them. The whole process could actually be also manual, but most hospitals had high volumes and therefore they need to use this automated systems for disinfection. This is the case of our institution. Like this one, the automatic processor will do the disinfection for you in only a matter of seconds. If you're using one of these processors, you should follow the manufacturer's instructions, of course. But again, if your institution does not have one of these machines, you could just manually do the disinfection with an enzyme cleaner, an enzymatic cleaner, just like the laryngoscopy blades are commonly processed. If the disinfection is carried with an enzymatic cleaner such as Cydex or OPA, the transducer should be washed again to rinse this off. It takes a few more minutes, but it's basically the same thing. Once you have your clean probe, a leak test needs to be done. This is basically a test to check for any leak of electrical current from a visible or invisible damage in your probe. Why is this needed? Who mandates this? The International Accreditation Commission, AIC, an organization endorsed by many surgical and procedural specialties, including the American Society of Echo. Since 2015, this commission requires that TE probes are leak tested and that the results are logged and kept records after each use. If your hospital is processing TE probes, they are doing these tests. But if you are not going to process your probe with a centralized system, which I highly recommend you do, you could do this yourself or whoever cleans your probe. Please refer to Sonosite's website or your TE provider's manual for a detailed description of this process. And what is and that is basically the entire cleaning and processing workflow. Really not complicated. Just need to figure out where you can do it in your hospital. How are you going to store this TE probe? TE probes should ideally be stored fully extended to avoid damage from permanent curvature on the shaft. This is the one we use on the left. It's quite expensive. If you don't have one, you may want to consider one of these single probe hanging systems shown on the right. And that concludes the first of this set of 2 webinars covering the most important aspects on the implementation of a resuscitative TE program. In the second webinar, we will cover what are the main training alternatives that some of us have used to educate members of our teams. I'm going to discuss briefly the issue of credentialing and privileges for the practice of point-of-care TE. And finally, I will provide a selection of some of what I think are the most important and best resources available to learn TE, obviously a fundamental part of any TE program. That is everything for today. You can find me on Twitter at FTeranMD. I'm always happy to engage in discussions and share my perspectives on the practice of echocardiography at the point of care. And if you have any specific questions or would like to reach me, you can email me or find me through resuscitativete.com. Thank you.